So how do we treat this? Here, the various measure modalities of treatment here are laser, anti-VEGF injection, and vitrectomy. So this is just a sheet which shows how we document everything like the post-conceptional age, the risk factors, and everything is documented, stage and zone of the disease in this sheet, so that we have a baseline documentation and also how the child is progressing or responding to a treatment. Yes, so this is a chart which shows again like how do we, which are the kids which need to be screened. So I have already enumerated. Then when do we perform the first screening? Before discharge from the NICU, or by 30 days of life, or 3 weeks is what we follow. Screening methods is screening usually is done by a trained ophthalmologist in NICU or even in the OPD if the child is stable with the indirect ophthalmoscope. Nowadays, with the advent, with the coming of wide-angle cameras, we are using a very non-invasive method, like even without using a speculum or IDO, we can document the retinopathy of prematurity. So why are we giving so much importance to this condition? As we all know, this condition can be potentially blinding if undetected and unmonitored. And this can give rise to various medical legal implications. So it is the prime responsibility of a pediatrician to make a referral to the ophthalmologist. And as ophthalmologists, it's our duty to do the proper screening and timely treatment for this condition. The next case scenario is of a 3 months old child, full-term child, normal birth weight with history of neonatal hypoglycemia, and the mother complains that the child does not have eye contact. So what is this? So just looking at the milestones, at 3 months, a child should be able to recognize the look at the mother's face. At 6, tries to touch object. At 9, it picks and it initiates action at 12 months and enjoys looking at pictures and draws pictures at 36 months. So we have two entities here. One is called delayed visual maturation. The other one is called cerebral visual impairment. In delayed visual maturation, there is no any risk factor. Everything, the eye examination is completely normal. So we usually observe it. But still the child does not have normal visual behavior of required for that age. But because there are no other risk factors and the rest of the examination is normal, we called it delayed visual maturation and we observe such children. The other entity which we are going to discuss is cerebral visual impairment, where the external eye examination can be normal or can have squint or a nystagmus. And this disc examination can show some pallor or it could be completely normal. And definitely these are the kids who have risk factors, developmental delay, and need early intervention. So here we come to the topic of cerebral visual impairment, where there is a damage to the visual pathways because of hypoxia, hypoglycemia, and other risk factors like intraventricular hemorrhage, trauma during the birth. So this is an important cause of profound visual impairment in children. Early diagnosis is important as intervention can help in bringing back some vision. And whenever we are approaching such kids, we ask for the birth, neonatal history, details of the condition, control of seizure, hydrocephalus, what are the medications and what are the MRI investigations saying, so that we are able to prognosticate the visual behavior. So depending on the amount of injury, if the occipital lobe is involved, we have visual impairment, color vision impairment. So otherwise, the dorsal stream is dysfunction is there. Then we have cognitive dysfunction like optic ataxia, simultagnosia, apraxia, and difficulty initiating hand-eye coordination, which are all cognitive dysfunction, but vision is fairly good. If we have ventral dysfunction, then we have impairment of visual recognition, route finding, facial expression, and visual memory. So how does improvement occur with whatever therapy we are giving? So it's not just the ophthalmologist who is working here. It's a teamwork with ophthalmologist, pediatrician, neurologist, occupational therapist, speech therapist. So it's basically a teamwork. What is the rationale? The rationale is that brain plasticity creates new synapses. It can reroute the old neural pathway and maximize the function of non-damaged structure. So we have that questionnaire where we examine the child, assess the child, and grade what is the status, so that we know after therapy how is the improvement. So there are three phases of CBI intervention. Like in first phase, we try to build the visual behavior, like helping with the fixation, localization, and tracking. In phase two, we are trying to integrate the vision with function, like gaze shifting, hand-eye coordination, imitation, and improvement in other cognitive behavior. In phase three, it is resolution of CBI characteristics, and we are paying more attention to the typical visual functioning. So how are we doing it? So this is a assessment, and this is how we do the assessment with the help of, these are called puppet faces, or we have something called Lia paddles, with the help of which we try and assess the smallest line which the child can see, or at what is the maximum distance the child can see. So these are the puppet faces and the Lia's paddles. We depending on that, we usually determine that determines the visual stimulus we are going to later use for visual intervention. So these are called puppet faces, and this is called Heidi's faces, where we see the contrast with which is able to elicit a visual response from the child. So this is a mirror test where we examine and see that if child is able to look at the mirror itself in the mirror, if at all, what duration is it able to look, how much is the latency, how long is the child taking time to look at the itself or to elicit a visual response. These are the things which we record, and so that we design the visual intervention later. So some of the vision stimulation and intervention therapies are like this. As I said, it's a teamwork. So here we are using a bright colored object. Also, when we are examining the child, we see if they have any color preference, like they like red or yellow. So accordingly, we use targets, which can elicit a response. We ask the mother to illuminate the face with the light so that the child is able to see the child. And also we integrate some of these things into the routine of the child. Like if we have understood the child is inclined to seeing a red, so we cover the bottle with a red ribbon or a red socks, which the child can easily reach for when it is feeding. These are all the forms of visual intervention therapy. So at SRCC also we have a dedicated unit which is working towards this direction, and we have various modalities to elicit to improve the visual behavior of the kids. So coming to the next condition, this is a 1-month baby which has been brought with a history of watering and discharge. So here we have our two differential diagnoses: neonatal conjunctivitis, which is the red eye which you see in the first month after birth, and the other differential is our congenital nasolacrimal duct obstruction. So these are some of the causes of neonatal conjunctivitis, where you see immediately after birth there is redness, profuse discharge, lipedema. Sometimes the cornea can get involved. Depending on the duration when this occurs, most of them are sexually transmitted through the vagina because of sexually transmitted diseases like gonococci. The involvement is seen in 2 to 4 days. In Pseudomonas, we see that the child acquires infection after 4 to 5 days. In chlamydia, it's about 2 weeks. And in herpes simplex, we see it in the first 2 weeks. Depending on the clinical features, we can distinguish the cause and accordingly treat with systemic antibiotics or topical erythromycin eye ointment. So another common condition, which is encountered in your OPD is a congenital nasolacrimal duct, where the parent gets the child with history of watering and discharge from the eye since birth. So this is a procedure called Roplas. It is regurgitation on pressure over the lacrimal sac. So once you give pressure over the sac area, there is regurgitation of mucus from the punctum. Then we call it as Roplast positive, which is suggestive of a congenital nasolacrimal duct. So in these cases, usually 90 to 95% of them resolve if we initiate Krigler's massage. So this is the video of the, sorry. This is the video of how the Krigler's massage is done. So we educate the parent and tell them they can do it with the baby finger, little finger, and do it at least 3 to 4 times in a day, 10 times per massage, per episode. So then next scenario is of a full-term baby with normal delivery, noted to have white spot in the eye with the absent reflex. So what is this? Is it congenital cataract? So congenital cataract comprises of 10 to 40% of childhood blindness. It could be unilateral or bilateral. It could be a part of syndromic association like inborn errors of metabolism like galactosemia. It could be seen with PDA, deafness. That is a part of congenital rubella syndrome. So any child with bilateral cataract, we usually do all these tests, the inborn errors of metabolism and torch infection and chromosomal anomalies if we are seeing the dysmorphic features. So the question is, do all cataracts need surgery in infants? Yes. If they are involving more than 3 millimeter of the central lens, then it definitely needs intervention, because it can later lead to amblyopia or the lazy eye. So if it is obscuring your view of the retina or the fundus, or there are signs of poor vision that the child is not seeing, the child is squinting, the child has nystagmus, poor fixation, yes, those children need surgery. On the right hand side, you can see that there is just an anterior polar cataract or some powdery opacities, which can be observed because they are not really obstructing the vision of the child. So when do we operate? Yes, as soon as they are fit for general anesthesia, which is generally 4 to 6 weeks after birth, or bilateral cases, at least in which the risk is little lower, we can wait till 6 to 8 weeks. So in very young children, less than 1 year, we usually do not implant the intraocular lens. So they have to be visually rehabilitated with aphakic glasses or contact lenses. Or in children more than 1 to 1.5 years, we replace the lens with the intraocular lens with which they can see. So the next scenario is of a 2-year-old child holding objects very closely. It's a preterm child. There's no ROP. Parents give history of wearing glasses. Does the child have refractive error or poor vision? Yes, so these are the common complaints which they come: difficulty seeing blackboard, holding objects closely, eye strain, headache, and tumbling. So the other symptoms of reduced vision, which could be an indirect evidence, could be squint, nystagmus, child keeping an abnormal head posture, poor performance in school, or could be totally asymptomatic. So what are we looking at? So how do we check vision in these small children? We have something called fixation preference. You can see how the child is resisting occlusion of the good eye and completely okay with when we occlude the defective eye. So we have optokinetic drum, we have flash VP, we have preferential looking test, which help us in estimating visual acuity in small children. So these are the other tests which we use for estimating visual acuity in pre-verbal and early verbal children. So a dilated refraction is very essential. And sometimes we have for screening plus optic screener. They are the screeners which do not need dilatation. It creates some noise and the child looks at the machine and we can get the refractive error with the help of this. It's basically a tool for screening. So refractive errors, my colleagues will be dealing, would be myopia, hyperopia, or astigmatism, which could be corrected with the help of glasses, contact lens. Refractive surgery is an option only after the age of 18 years. So the next patient is a 8-year-old child with defective vision detected during eye checkup, school eye checkup. So external eye, everything is normal. Even after giving glasses, the child's vision is not improving. So what is this condition? So this is called amblyopia or lazy eye. Even with the proper refractive correction, the child is still not able to use the vision completely in that eye. So what are the causes? So could be a refractive error, which can be high. It's something called anisometropia, where the refractive error is different in both eyes. So there is a rivalry between two eyes leading to decreased vision in one eye. Squint could be the cause of amblyopia, or because of cataract or a corneal opacity or a ptosis or a lid lesion covering the visual axis. These are the different causes of lazy eye which need to be identified. So what is the time frame, or why is the clock ticking? Yes, the neuroplasticity is noted only till 8 years. So the treatment for amblyopia works best if initiated before 8 years of age. So screening is of utmost importance, and wearing of glasses, and specifically screening at birth. So we recommend screening at birth for red reflex at 6 months to look for squint, and all children need an evaluation for refractive errors and other anomalies by 3 years of age. So these are the different modalities of treatment for lazy eye. We can patch the eye with the occluder, or we can use some occluders over the glasses. At present, we also have computer-based amblyopia exercises, and of late, we also have VR-based games which help in treating amblyopia. The next case scenario is a 4-year child who is complaining of intermittent squinting with normal vision. So what is the right age for doing surgery? Do all squints need surgery? Yes, first thing we need in evaluation of any squint is we try and differentiate if it's a true squint or a pseudo squint. Pseudo squint will have, like the child shown here, epicanthal folds sometimes, or a broad nasal bridge can lead to an appearance of pseudo squint. But yes, if there is a true squint, what do? We we correct the refractive error. And some other causes like this can also present as squint. So we do a refraction and a dilated fundus examination. So yes, there is a role of neurologists. So whenever we have children who come with acute squinting or a nerve palsies, we refer them to a neurologist. And squint with papilledema is also something which warrants neurological evaluation. So management of squint, as I said, correction of refractive error, patching, convergence exercise, and then surgery. Surgery, it's very important to understand it's not a cosmetic surgery. Eyes are aligned to just develop the binocularity. If there is a constant squint, we need to operate irrespective of the age. Intermittent squint can be assessed, and as and when the binocularity is threatened, we operate. But yes, there is no upper age for limit for surgery, and squint surgery is for restoration of binocular vision, and it is not a cosmetic surgery. So the next common condition which we see in our OPD is a child with a red eye. So allergic, these are the two important differentials. So you get a child typically in summer with rubbing the eyes and pink eyes, with not very lot of discharge, but definitely showing a seasonal variation, can have a history of asthma or skin rashes also. So this is the clinical picture where you can see the papillae and the nodules at the limbus, and which can progress to a corneal ulcer. So this is called vernal allergic conjunctivitis, which is very seasonal. Typical eye rubbing is seen. So this we treat with topical antihistaminics, mast cell stabilizers, and steroids as and when required. Whereas in infectious conjunctivitis, usually you can have a history of viral infection, or you can have a history of contact with a relative or a sibling who has had an episode of conjunctivitis. Here you can see subconjunctival hemorrhages. So you can have preauricular lymphadenopathy, pseudomembranes can be seen. So here this we are treating with prophylactic antibiotics. Most of the times it's viral conjunctivitis. We treat with prophylactic antibiotics, and it takes about 2 weeks to resolve. The last important thing which we need to know in a child is a white reflex in the eye cannot be missed. It could be due to a threatening retinoblastoma, Coats disease, cataract, ROP, persistent hypoplastic primary vitreous, or a toxocara. So this is a simple test which every pediatrician can perform. It's called Bruckner's test, where we use a direct ophthalmoscope and throw light at a distance of 1 to 2 meters on the glabella of the nose, and we notice the red reflex in both eyes. So what are we noticing when we are seeing the red reflex? It should be equally glowing in both eyes. If at all you feel that the glow is poor in one eye, it could be because of cataract or other media opacity, or even in case of a squint, if you see the reflex coming from the eye with squinting is brighter. Or the other importance is to determine the refractive error, where you can see a small crescent like thing depending on myopia or hyperopia. We see the crescent above or below. But for a pediatrician, yes, you can detect cataract, you can detect a white reflex, you can detect a squint with the help of a Bruckner's test and promptly refer such children. Lastly, congenital glaucoma is very important. All eyes with watery eyes are not NLDO. It could be just a congenital glaucoma. So what do you have to see? You can see the enlarged corneal diameter with a hazy cornea, and a typical feature is photophobia or blepharospasm. This is something which needs early surgery and identification. So lid lesions commonly seen. You can have a sty, which is infection of the eyelashes, treated with topical antibiotics and hot fermentation. And chalazion, which is a granulomatous inflammation of the meibomian gland. It's treated with hot fermentation, incision, and antibiotic steroid eye ointment. And if not resolving, then we go ahead with incision and curettage. But recurrent chalasia in a child should always we suspect that they have any underlying refractive error and they keep rubbing the eye. So always rule out the underlying refractive error. Ptosis is another, or drooping of the lid is another cause for amblyopia, which can cover the visual axis and needs a early surgery. So injuries are also not, many a times I get calls from pediatrician friends who say that injury is there. So these are the things which you have to look for. It can be a just minor epithelial defect, or there could be a blood in the anterior chamber, or it could be as ghastly as a penetrating surgery, which needs a penetrating injury with iris prolapse, which needs surgery, and the other one commonest is a chemical injury. So this is the table showing ophthalmic examination at various ages. So we need to do at birth, look for the red reflex, look for the symmetry of face and eyes. Anyway, they will have poor fixation, and they will have squint most of the time. It is exo. But yes, when you see the child at 3 months, they should have a good fixation and a smooth pursuit. Look for the Bruckner's for a bilateral red reflex, and they should have good alignment at this age. Children 3 years and older, we need to examine them for visual acuity, again red reflex and any squint. So my take home points are: it's important to assess the red reflex in the eye of a child after birth and maybe at first vaccination with an ophthalmoscope, and be aware of congenital glaucoma as a cause of tearing. Even children with normal birth weight but stormy perinatal course can have retinopathy of prematurity. So please send them for evaluation. And all children with squints need a detailed examination to detect lazy eye and correction of squint to restore binocularity. Children with birth asphyxia, hypoglycemia, and seizures are prone to cerebral visual impairment. Visual stimulation and visual intervention definitely helps. Thank you.
Thank you, Dr. Harsha. That was an excellent presentation. Do we have any questions for Dr. Harsha from the audience? So, Dr. Rujul, shall I go ahead with my presentation? Dr. Rujul?
Can we ask questions directly?
Yes, ma'am, you can directly ask questions, no problem, ma'am.
Yeah, so I just wanted to ask, like you said about these allergic conjunctivitis. So how do we tell them to put these drops? Once you said one was a steroids and one was antihistaminic. So how do we tell them to put alternate, or like for how long?
How long depends on the severity of the allergic conjunctivitis. So generally, we give the topical antihistaminics and mast cell stabilizers are given just once a day at night, bedtime. Whereas steroids, usually we taper depending on the condition. We start 4 times a day, and every week we have a tapering regimen, like 3 times, 2 times, and so it is continued for a period of 1 month. But yes, we need to keep seeing the child on slit lamp whenever we put the child on steroids.
How do you treat blepharitis, madam? How do you treat blepharitis in children?
Blepharitis is treated by lid cleaning with the help of a diluted baby shampoo. They can dilute and clean the lid margins with the scrubs, and then a topical antibiotic eye ointment should help. If it is secondary to dandruff, if it is secondary to dandruff, then the dandruff also needs to be addressed. If it is seborrheic, then yes, dandruff needs to be addressed. Yes.
Fine.
Any more questions? Shall I start with my presentation? I'm Dr. Hemlatha.
Yes, ma'am, I think we can start. Our next speaker is Dr. Hemlatha. Madam is also a senior pediatric ophthalmologist associated with SRCC Children's Hospital. Ma'am's topic is going to be on myopia, which is the current epidemic. And I'll hand over to ma'am. Ma'am, you can share, we'll just check your mic and the screen once.
One
could
second.
share yes, ma'am.
I'll open my presentation.
Yes, ma'am, I'll wait.
So I'll go to share screen.
Yes, ma'am.
Is my screen seen?
No, ma'am, you will have to share the entire, like open the PPT and then share screen when you click on that.
1 second. I have the PPT opened in my desktop.
We can now share screen.
Yeah, we can see the screen now.
Yes, ma'am, we can now see it.
Okay. So good afternoon, everyone. I am Dr. Hemlatha. I'm a pediatric ophthalmologist at SRCC Children's Hospital. Today, I would be speaking about myopia, the current epidemic, and also the latest modalities of myopia treatment, as Dr. Neepa is traveling. So I would be covering that topic as well. So basically, myopia is a nearsightedness where a child can see near objects clearly, though he cannot see objects which are far at distance. Basically, the reason for this is in a myopic eye, the eyeball is slightly bigger in size. So the parallel rays coming from infinity, instead of focusing on retina, they focus in front of retina. So the objects look very blurred. So sometimes when a child is only looking at objects inside the room or only sitting in the front bench and looking at the blackboard, they may not realize it. But when they go towards the end of the class or from the back bench, they are able to not see very clearly. This particular week, May 19th to 25th, is being observed as Myopia Awareness Week. Now, the main purpose is to educate and create awareness about myopia and also the initiatives which are aimed at highlighting the importance of treatment of myopia. So, myopia is of concern because it is increasing in numbers very rapidly. According to the World Council of Optometry, by 2050, up to 50% of world population may be affected by myopia. Now, if we compare it with 2010, there were 1.9 billion people, and it's projected to rise to 52%. That is almost double. At that time, it was 27%. By 2050, we believe that 52% of world population would be affected by myopia. And the concern is that in 2010, 70 million, that is 2.8% of these people affected with myopia had high myopia. But we are projecting that this high myopia will also increase considerably in this coming years. And high myopia is associated with a lot of complications. Now, coming to global distribution, in Asia and Southeast Asia, due to some racial changes, there are much more incidences of myopia. And the earlier the myopia develops, the faster it progresses, and there are risks of developing high myopia and its associated complications. Now, this rise in risk is also driven by lifestyle factors like increased near work, especially in school, reduced time outdoors because children attend various classes, and along with genetic predisposition. If we see in this picture, in Southeast Asia especially, the myopia incidence is very, very high. So in a recent study, it was found that 31% of children, that is the ones who are going for a productive life, they are going to be myopic. And this is much higher, that is just double the prevalence reported a decade ago. So hence there is a need to control this myopia progression and aim at its treatment. We see that myopia is increasing very rapidly in the coming years. Now, myopia is a public health concern because 80 to 90% of high school graduates are the ones who are affected by myopia. Now, these children are only going to be the workforce in the coming future. And of these, 10 to 20% have a pathological myopia, that is, myopia associated with other eye problems. Now, this myopia is a leading cause of vision impairment and it can lead to significant economic impact. It can affect also the quality of life, their physical, emotional, and social functioning. Now, if we see this picture, in the above picture, the light is falling on the retina. When there is an axial elongation, the main reason for myopia is the eyeball becomes bigger and hence the light is not able to focus on the retina. Why is it important to control myopia is high myopia is considered a myopia more than -6 diopters or greater. High myopia, in addition to wearing glasses, it is associated with serious complications like early onset of cataract, more risk of developing glaucoma, retinal problems like retinal detachment, and myopia macular degeneration. So, in moderate myopia, the eyeball is slightly longer, whereas in highly myopic eye, the eyeball is much longer, and this is the posterior part of the retina which gets most commonly affected. Now, in pathological myopia, there are also risk of developing other eye problems which can cause irreversible vision impairment like choroidal neovascularization and macular holes. The person also becomes more prone to develop glaucoma because the peripapillary region is distorted by mechanical stretching of the globe. So hence the risk of blindness increases if a person has pathological myopia. So these are the various complications, like a myopic person can develop early cataract, early glaucoma. There can be chances of retinal detachment, and then other retinal problems like myopic macular degeneration, chorioretinal degeneration, other problems like lacquer cracks in the retina, and a condition called posterior staphyloma. Now coming to how do we treat this myopia and how we prevent its progression. Now, I'll be talking about various eye drops and spectacles which we use, but there is no financial interest in any particular company or any type of lenses. So, to control myopia progression, a combination of treatment is required because myopia is multifactorial. We need to make lifestyle changes. We need some medical interventions in form of drops, and also we need to use specialized glasses. So, in lifestyle adjustments, it is important that a child spends enough time outdoor. This helps in two ways. One is whenever a child is spending outdoor, he is getting enough amount of vitamin D. Vitamin D deficiency is also a known risk factor for myopia progression. Also, whenever a child is playing outdoors, his eyes are looking at a far distance. So there is not an excess strain on accommodation. Then it's important to reduce near work, especially near work which is on the digital screen like tab or mobile. And if a person has to do a lot of near work in terms of reading or school work, they should take frequent breaks, and then they should give rest to the eyes periodically. It is important to ensure good illumination and a proper posture while working. In a growing child, it's also important to have a balanced diet which contains vitamin C, vitamin E, and omega 3 fatty acids, which can support eye health. Coming to medical intervention, the most effective drops which helps in myopia control is a low dose atropine drop. Then we have myopia control glasses. We have multifocal soft contact lenses. There is a technology called orthokeratology and also red light therapy. We'll come to each one by one. Now, low dose atropine drops. Atropine was initially used for relaxing the eye muscles, and it was used to treat inflammatory eye conditions. Then there was a hypothesis that maybe by relaxing the eye muscles, atropine can control myopia progression. Later studies found that atropine is likely to work on its receptors in the retina and sclera, and it in some way prevents eyeball elongation. So, if the eyeball doesn't elongate rapidly, then the axial length will not increase, and hence myopia progression can be retarded. The most commonly used drops which we use nowadays is 0.01% atropine, and this, when used regularly, especially during the phase of peak growth, helps you retard myopia progression. Now, two, three companies are available which prescribe these drops. One is Myetro and another is Kitro. The most important thing here is whenever we are prescribing the drops, it is important to prescribe the dosage, which is 0.01%. If we prescribe the normal atropine drops, which is 1%, then it can cause a lot of blurring of vision, because 1% atropine completely relaxes the accommodation and the child may not be able to see clearly for coming 2 to 3 weeks. So it's very important to tell them to use only low dose atropine. And in children who show progression even with this low dose atropine, the atropine is going to come in a higher strength of 0.05%, which may be available after a few months. In some children, it was noticed that once you stop this drop, there is some rebound effect. That is, their power increases little rapidly. But when you compare the entire amount of myopia which is got by rebound, it is in much less children who experience rebound. Most of the children do not experience rebound. Then glasses for myopia. We all know that the most common way of treating myopia is prescribing glasses. These are concave lenses which make the lens is made in such a way that they shift the focus of the light from the front of the retina directly to its surface. And they are prescribed in diopters, and they begin with a minus sign. Now, in very high myopia, when a child has to wear a very thick power glasses, we prescribe them high index glasses which are little thinner. The advantages, it is a little easy to manage for the child, and also the peripheral aberrations are much less. Anti-reflective coating can be used in these glasses to provide better quality of vision and comfort. In children with progressive myopia, we go for specialized glasses known as myopia control glasses. Now, in the last 8 to 10 years, these glasses have become popular following a lot of research which has been done. There are two technologies which is used. One is the DIMS technology and another is the HALT technology. Now, DIMS means defocus incorporated multiple segment spectacles. Now, these spectacles are specifically designed to slow down the progression of myopia. Picture, we can see that the central portion, so this centermost portion is when we'll have a clear vision, and these lenslets cause a peripheral defocus, and hence they prevent myopia progression. peripheral vision, and hence they prevent myopia control. Myopia control, especially in children whom there is a rapid increase in myopia. Now, the benefits is that if we can control the total amount of myopia, then there are less chances that child will develop any retinal problem and other problems like glaucoma and optic nerve damage. Another technology here is a HALT technology, which is by a company called Essilor. Here there is Stellest lenses as a commercial name. Now this involves a constellation of 1021 spherical lenslets or tiny lenses which are arranged in 11 rings within the lens. So here there are multiple lenslets we are arranged in the lens. Now the centermost portion provides you a clear vision, whereas the peripheral portion is for myopia control because it creates a volume of defocus. So these lenses are also very effective in preventive progression of myopia. Now, clinical results have shown that they reduce myopia progression by up to 67% compared to standard single vision lenses. And they provide clear vision for distance correction, so making it a comprehensive solution for myopia management. Now, same principle, we have myopia control contact lenses. Now, here these lenses are worn directly on the eye. Now, these lenses also have multiple segments. The segments create a central clear vision so that at the macula you have a clear image, and the peripheral rings, they cause a peripheral defocus, and then they attempt to prevent myopia progression. Now, research shows that this helps the eye from growing longer, and it can slow down myopia progression by approximately 59%. So the commonly used Sunday disposable lenses by Cooper Vision, and in some cases they are also helpful in presbyopia, but their main role is in myopia progression. In comparison with glasses, there are some problems with contact lenses because the parent should be able to insert and remove. They have to maintain eye hygiene, and there is chance of infection. So these are the problems with these contact lenses. And another technology called do is we make the child wear rigid gas permeable contact lenses throughout the day. Sometimes it is worn overnight also. Now these lenses are worn all the time. If you see before the lens, this cornea is little steep. Once these rigid gas permeable lenses are prescribed, it flattens the cornea. So over a period of time, the cornea gets flattened. When the cornea gets flattened, the number automatically lenses, and with ortho K lenses also some management would be individualized, whichever child responds to whichever technology better, we prescribe it to them. Now, regular eye exams are important because the earlier you detect myopia, the sooner you can start with your intervention in myopia progression. Sometimes children may not realize that they have an eye problem and may come to know only while doing a routine eye examination. It's also possible that a child may be able to see clearly from one eye and another eye may be having a spectacle number, and the child may never realize that they have a problem, and that eye will become amblyopic. So it's very important to have a routine eye examination done, and especially in children whose parents have high myopia or whose siblings have high myopia. Now, the recommended schedule is all children should be checked around 6 months of age by the pediatrician. They have to check whether the child is fixing, following, maintaining eye contact. Preschool children should have an eye examination between 3 to 5 years. Even if they cannot read the normal Snellen's charts with alphabets, we have various pictures with which we can assess that they have a proper eye examination. And after that, if they do not have any eye problem, yearly they should be checked, because up to the age of 18 years, the number can increase. And if they do have a refractive error, they should be checked every 6 months so that we can give them the correct glasses and also give them the correct treatment. proper intervention at the various stages of myopia progression. So the important considerations are we need to do early intervention and we have to start as early as possible to prevent myopia progression. Every technology may not suit every child, so we have to do trial and error and see which technology suits which child. So frequent follow-up is necessary. And whenever there is an eye problem, the child's parents should bring them to the eye doctor to check for the various options for myopia control. It's very important to address this issue on public health initiative, because nowadays many schools give lot of work online. They use online methods of teaching. Even work is given online. So schools should also consider that too much of screen work, especially near work, can lead to myopia progression, and hence they should cut down on the screen work. And modification in school design where they involve a lot of outdoor activity also helps to prevent myopia progression. Thank Are there any questions?
Thank you, ma'am. Ma'am, Himika here. I had a doubt.
Yes, please.
Ma'am, what is the age group for myopia control lenses? In which age can we give the contact lens? Am I audible? In which age can we give the
Dr.
myopia
Himika,
control
you're
contact?
audible, but I think Dr. Hemlatha, ma'am, her screen is, I think, frozen as of now.
No, no.
Now we can-
Himika is asking a question, I guess.
Yes, ma'am.
Yes, ma'am.
At which age group can we give the
Yes,
myopia
Dr.
control?
Himika. I'm not able to hear. At which age can we give myopia control glasses? That's your question.
Lens, contact lens.
See, contact lenses, generally we wait for the child to be little older, because they should be able to handle the contact lenses. Otherwise, the parent has to insert it, they have to remove it. And if they go to school and if it falls down, they may not realize it. So a child who can handle is responsible, maybe around 9 to 10 years, we can think about it. And earlier, if the child is very responsible, it varies from children to children. And myopia control glasses are a better option because they are easier to handle. And maybe once the
Yes.
child is a little older, we can think about the contact lenses.
Thank you.
We can go to the next speaker, Dr. Himika.
Yeah, I will be speaking.
We
Madam
can
has
start with Dr. Himika's presentation.
Yes, ma'am. So is the presentation mode visible now?
Yes, yes, it's visible.
Good afternoon. I thank the organizing team and especially Dr. Rujul to invite us on this platform to discuss common eye problems. My name is Himika and I'm one of the eye doctors associated with SRCC. And today we'll be discussing about digital eye strain. And it is a universal cause of headache, whether we are pediatricians or adult practitioners or adults or kids, everybody is facing this problem. Dr. Hemlatha already touched a bit about it. So the next few slides will discuss how to deal with it and what are the do's and don'ts.
So my first question to the audience is that what is CVS? Most of us went through residency. What did CVS stand for back then? Any answers? Anybody who's awake and paying attention, please respond.
Cardiovascular system.
Thank you very much. We have a new definition now. As per the generation, I think it's called Generation Z or the millennials. It is now computer vision syndrome. It is referred to as a combination of digital eye strain, and it is associated with eye and vision problems due to prolonged use of the computer, tablet, or e-reader. Just so what are the common symptoms of this? I'll just try to write this one. So the computer vision syndrome, also called digital eye syndrome, is associated with eye fatigue, itchiness of eyes, dryness, blurred vision, double vision, and headaches. Obviously, it occurs when there is increased screen time. Now, over and above the eye problems, there can also be neck issues like shoulder pain, neck pain, headaches, and backaches. So this is all associated with prolonged desk time and prolonged screen time. So what are the common symptoms that the patient comes to us with? And most of these symptoms are pretty similar in adults as well as kids. Only thing is that they kind of tell us in a different way. So they typically say if the child is slightly bigger, above 6 years of age, they say that the eyes are heavy. They want to keep the eyes closed. There are headaches. There's frequent blinking. There is blurry or double vision. And there are runny letters, means the letters seem to run or kind of fuse into each other when it is a finely print media. So these are some common problems or common symptoms. So the common thing that we have to rule out is a refractive error. So it's a good idea to do a repeat check on the spectacle number. Now, many a times we ask our patients, we feel that you need an eye checkup, aankh check karaya. The parents will immediately reply, हाँ, कुछ नहीं है, चश्मा नहीं है. Now, the second question that is of importance is कहाँ check करवाया? Because if they go for that free eye test in optical shops, there's a high chance that a accurate eye evaluation has been missed out. So a comprehensive dilated examination, often in kids, is very important to come to the conclusion whether the child has specs and what is the correct power that the child needs to actually wear in his or her specs. So remember this, that quality is very important, especially in kids. Okay. Undercorrected or uncorrected vision problems can be major contributing factors for digital eye strain. Now, the second step which happens when we know that the child or even you as adults or as parents have specs. The second question that comes to our mind is what kind of specs? Because what happens is that, wait a minute, I'm getting a lot of, Rujul, apart from me, nobody else can admit the people who are joining now. Dr. Rujul?
Pardon?
Yeah, I was getting a lot of, people trying to join. So very tough for me to do admit as well as doing the lecture. Anyways, so the second part is that do we actually, what kind of spectacles that are we supposed to wear and how useful are they? So then they'll always say go for anti-glare. Now, what are anti-glare measures? These are kind of either the specs will have a coating or your screen will have the coating. They minimize the glare on the computer by using a glare reduction filter. or by repositioning the screen so that the glare is less. Or you can, if it's a very bright room, you use drapes, shades or blinds so that there's not too much of sunlight bouncing off the screen, because then your eyes will hurt. And another idea is to keep the screen as well as your specs dirt free. Remove all the, grease or the fingertips stains that are there. And it's a good idea to use the Selvet, that soft cloth, and the spray for cleaning, not really your random handkerchief or kurta or shirt, It contributes to scratches on the chashma. Just a personal tip for taking care of your specs. Now, the second thing is the new kid on the block, which is blue block. Madam, blue block specs लो sir, ये best है, इससे आपको कुछ नहीं होएगा. So blue block glasses are supposed to have filters which are said to decrease the amount of glare, amount of light that enters the eye, decrease the amount of long-term retina damage that can occur because of so much of digital media light entering our eyes. And it is known that whenever we use excessive screen time, our circadian rhythm and the melatonin secretion is tampered with, and the sleep cycle is affected. The time to go off to sleep gets delayed if you land up seeing digital media. So blue block is supposed to block all these and prevent these side effects. Now, these are the things that we get to see when we check, for example, Google, Flipkart, Amazon. No financial interest. Many of my friends work for these organizations. But let's look at the fact versus fad. Okay, if you're going to do a proper search on PubMed, you'll know that blue light filtering spectacles may not attenuate any symptoms of eye strain over short term. It also said that there was no randomized controlled trial which said that there was a change in macular health or the retina health, as well as the melatonin levels. Not sure if this is seen. So very frankly, sorry to burst the bubble, but blue block is of very limited use. If we don't give it, nothing will happen. Why am I saying this? Is many a times when, people think, okay, we are doctors, what kind of chashma should we go for? Spectacles are costly. Dr. Hemlatha spoke about such good, interesting myopia regression specs, which are really necessary for the patient. But then the blue block part, remember that it's just a fad, not really of any much advantage. Anti-glare can be useful. Yes, that's a good thing. Anti-glare in adults is almost a necessity these days because all of us use screen time. Anti-glare in kids may or may not be used, but blue block in kids is of no consequence. The next association with this computer vision syndrome is itching, redness, and burning sensation. In fact, we have small kids who can't even describe burning sensation. They say, I feel as if soap or shampoo has gone in the eye. Jaisa mama head bath dete हुए जैसे आंख में soap जाता है वैसा feeling आ रहा है. So this is the sad reality that small kids are now facing computer vision syndrome associated dry eye, which is unheard of. And they are coming up with their own nomenclatures to describe their symptoms. And many of these patients also have watering. So this is the paradox that any case of dry eye, whenever the eye has a lack of tears, the body tries to overcompensate, and then we'll end up having reflex watering. So who is at risk of for all these things? Obviously, anybody and everybody who's using increased screen time, whether it is mobile, PC, laptop, tab, or the large screen or the computer or the television screen. Especially for 2 hours or more, if you're using it without a break, then there's a problem. If the viewing distance is close or the complexity of task being done on a very fine print or a small screen is very high, you want to, for example, edit an article, go through an Excel, edit that Google spreadsheet on an iPhone, perhaps, or any of the smartphones, then those all things will contribute to your eye strain. Anybody who has existing dry eye and anybody who has an uncorrected spectacle number, those people are more prone. Obviously, poor lighting, room is too dark, or excessive lighting and excessive glare will also contribute to eye fatigue. So what is the one-stop solution for all this? Very simple. Stop using all digital media. But in today's practical world, is that possible? The paradox is, the proof is in the pudding itself. I'm giving a talk on reduced digital media time, and it's a Zoom call which is totally digital. We all are facing some amount of digital media time right now also. So in the current scenario, especially post-lockdown, we really can't, life has changed forever, and even pre-lockdown, there were many things which needed digital media exposure. So what are the various negotiations that we can do? Because we can't just stop using all digital media. So let us look at what can be done and what cannot be done. So often we have parents saying, नहीं बस खाते समय टीवी देखती है या टैब देखता है. Otherwise, our child does not use tab. Is that okay? Is that a reasonable negotiation? The answer is a big no. Now, for all of those of you who have found time to be here today afternoon, if you just follow this one slide and then even if you disconnect, I wouldn't mind. Okay, or the organizers will, well, but I wouldn't, because this is the commonest problem in India, where we Indian parents, even I am one Indian parent, we want our kids to eat a lot, eat without fuss, keep eating, eat regularly. And we feel that this short-term solution of making them see a video and feeding them is the best way out. Now, what happens in this is that although it gives us as parents or them as parents, those of us who are parents, immediate gratification that, okay, ये बहुत टाइम लगाता था पर अभी बहुत जल्दी खा रहा है. I have to admit to people. What happens is these kids will never experience the taste or texture of food. They will obviously lose out on the socializing and having conversations while having food. They will never learn from watching others eat, the etiquettes, the techniques, and the concept of fullness versus hunger. Because you put on the tab, whatever you put on the plate, whether it is good, bad, or ugly, it is just shoved in the mouth because the child's entire attention is on the video screen. Okay, so it contributes to mindless eating. And because of the mindless eating, later on, these kids are prone to severe forms of feeding disorders, which is either anorexia or obesity. So the best trade-off would be that you tell the child to finish their meals and then you may see your favorite cartoon, but do not eat and watch at the same time. So this is negotiation number 1. What do we have for negotiation number 2? Okay, here my screen's blocked. So the second negotiation that we face a lot from parents is सिर्फ पढ़ाई के लिए यूज करता है. He is very smart. He's hardly 2 years of age, not yet entered kindergarten or any formal school, but he knows all the nursery rhymes and he's also kind of reciting them all. And you'll notice that the child doesn't really know much, but he or she knows how to recite the entire alphabet and some nursery rhymes in a total anglicized Western kind of accent. So what has happened is this child has been obviously exposed to a lot of screen time, and sometimes parents find that very cool and they kind of encourage this behavior. So this is also quite a problem. So when we look at, again, evidence, what does evidence say? The evidence says that it can have a negative effect on student learning. And some of these studies are pre-lockdown. Now, these are some studies from Nordic countries, and they are pre-lockdown. Even before lockdown, people had started looking into how good is it to use this digital media for study purposes. And it's like a double-edged sword. And more or less in very initial, in mid school and preschool levels, if you're going to introduce this to them, you're going to land up in trouble. That is what roughly most of the data tells us. So this is another study, a very nice one, where they said that students at risk of digital media addiction, okay, experience learning difficulty. So if you are going to introduce digital media rampantly in the study curriculum, and this is very important, and even Dr. Hemlatha spoke about it. Currently, we are looking at, digitalization of education system. Blackboards have converted to smart boards. Some things are very good. Those of our patients who are suffering from low vision, they are better off on the smart boards. I agree. And they don't have to, depend on the teacher's handwriting. The print is big. There are a lot of permutation combinations available. It's easier for the teachers, perhaps. But this exposure is coming with a price, and we have to be aware of this, that in general, it does not contribute to very good academics. That is what most of the studies tell us. So we have to really incorporate this, but we have to be very cautious in incorporating this in the education system. In fact, I always tell our patients, the parents of kids, those of you who are there in the parent-teacher associations of the respective schools, please put this message across. It's not too cool. The smartphone and smart tabs will not make the child smart. It might make the child dumb, or it might make the child an addict. So this is another Indian study where they said that it was more of a surface learning, like the kids get familiar with the topic, but they don't really learn the topic in depth. So no deep learning occurs, and the short-term memory suffers. So this is another thing. So their short-term memories are also suffering. Again, there are some studies talking about worse performance in mathematics and academics. In fact, when I was an assistant professor with one of the medical colleges, we asked the students, the medical students from second year, ophthalmology is taught in second year, MBBS and third year. We said, what do you prefer? They said that, madam, the day you don't bring that PPT of yours, and you use the chalk and board to explain the topic, we are able to retain it better. So that was directly from the horse's mouth. So how much of digitalization is going to help academics? It's a very big question. So be careful, don't fall for it, that smartphones will make a smart child. No, that's really not gonna work. So what else can we do? What are the other negotiations that we can do? Because we can't just stop using digital media. One is the 2020 rule, which is very famous, and I've also put it up in my clinic. And I would say that all of us here who are practitioners should put this up in our clinics, because everybody's exposed to digital media. So take a 20-second break for every 20 minutes of screen time and look at an object 20 feet away. Furthermore, we encourage them to, break free from that place where they are sitting, because they say that sitting is the new smoking. So you don't want the child or the adult to be sedentary. They should get up from their chair, go for a walk, go to the washroom, go drink water, come back. So that way even the body is a bit active. Other things that can be done is think, blink. So each time we blink, the tear films of our eyes get refreshed. With that, the tear lubrication is more efficient. If we are focusing on the screen too much and not really focusing on our blinking, like we have heard the Hindi terminology aankhein faad ke dekhna. So something which is over interesting or engrossing, we'll end up seeing and we forget to blink. The normal blink rate is around 13 to 14 times a minute, equivalent to our respiratory rate. But when we are engrossed in the screen, we might forget to blink. So consciously encourage yourself and your patients or the kids around you to think and blink, wear appropriate spectacles. Okay, I have nothing against any optician. I have wonderful friends, but yes, for a child, at least the initial evaluation and annual evaluation has to be in an eye clinic setup where SOS dilating drops can be put to evaluate for the correct spectacle number, not that free eye test ₹0 में करवा के बता दिया चश्मा नहीं है. Don't fall for that. Third, ergonomics, location of the computer screen should be either at the eye level or below, 15 to 20 degrees below. Okay. And try to alternate the screen time with other tasks. So if it is at a workplace, they can go and maybe take a photocopy or go have a meeting, come back. So it has to always alternate. Even for kids, we tell them. So kids who are specially preparing now, in fact, this entire month, we got a lot of kids preparing for NEET. So they've just given their NEET exam and they've come to us. Okay. So we always tell them that you alternate your screen time with other things so that your total exposure is not prolonged in one go. So this is the correct sitting posture where the screen is up, at eye level or slightly below. Legs are almost, thighs are parallel to the ground. Body is upright at 90 or 100 degrees. And the feet are again placed down. They should not be dangling. Okay. So this is the typical correct sitting posture when we are looking at the screen. And whenever possible, let it be a bigger screen. So this is another thing that we encourage our parents. For example, now there are WhatsApp groups for every class. If the child is going, enrolled in the regular academic school class, there's one. Then there will be some, if the child is going for a football class or whatever, all homeworks, music class, a baker's class, there are separate WhatsApp groups. So what we encourage them to do is use WhatsApp web, because that helps them that reduces improves the magnification and reduces the fine work or the complexity of the task that needs to be done. So what are the treatment options when it comes to computer vision syndrome? Proper spectacles after checking eyes for refractive error. Tear substitutes or lubricating eye drops are a very good option. So that is one thing which can be universally used. There are a zillion brands in the market. Many of them are preservative free. These do not have any active ingredient. It is like how if you are feeling thirsty, you drink water. So these are just tear substitutes. They are not really medicines. And whenever you are going to expose yourself or the child or the patient to a lot of screen time, it is a good idea to keep them handy. They keep the eyes lubricated, hydrated, prevent the dry eye, and overall maintain the goodness or the comfort for the eyes. Then appropriate lens tints. Now, sometimes we use obviously anti-glare. Then in some patients, depending on individual customization, we might also use an amber tint, which helps them to enhance the contrast and reduce the glare, and so on and so forth. So we can use obviously the correct kind of spectacles. And if it is still not, responding, then please reach out to an eye doctor close by. So again, we are touching a bit on media consumption in kids. It's not just eyes, it is the entire brain and the psychology. And if I were to go deep into this subject, then I would have to invite the developmental pediatricians and the child psychologists for this lecture, because it has been proven to have a negative effect on school academics, then association with autism, obesity, delayed speech, and mental disorders. And I wouldn't like to preach to the converted. You all are, most of us here are pediatricians. We are the opthal people. The audience are more pediatricians. You know more than us what we are kind of facing these days. So these are again some very nice articles, and mind you, this is from a lecture that I had given way back pre-lockdown in 2018. So these are pre-lockdown lectures, and even then we knew that excessive computer use is associated with inadequate sleep quantity, poor sleep quality and excessive daytime sleepiness. Okay, so that's why these kind of things, then that's why these rules like have the bedroom media free, dining table should not have the media at all, and so far and so forth, is very important for overall health of the child, and I would say the family also. So again, obesity is known to be a very well-documented outcome of increased screen time, more or less goes hand in hand with that mindless eating. सिर्फ खाना खाते समय वीडियो चाहिए और कभी नहीं चाहिए. बहुत पतला बच्चा है, बाद में ऐसा ना हो कि बहुत मोटा हो जाए. So that is another thing you have to hold your horse. And as pediatricians, as primary caregivers of the vast pediatric population that our country has, it is very important that these points are put across, that we have to curb it and nip it in the bud. Then another study again demonstrated that shorter duration of screen time was associated with a better performance in maths and overall better academics and achievements. The other concept is that of autism, where digital screen reality leads to virtual autism. Now, this is not directly my area, but because I also render vision therapy and I'm trained in vision therapy, we do land up dealing with a lot of autistic kids. And more often than not, we also come across the pseudo-autistic spectrum, where the child is getting immediate gratification from the tab and does not feel the need to interact, to socialize, or to communicate or verbalize with the surroundings. Often they are lonely because of parents who are not at home, who go out to work, and the child is left in care of a caregiver or somebody who's not from his or her family. And these all are having a very terrible negative kind of effect on their entire personality. So behavioral issues is a big problem with excessive screen time. In fact, even in our clinic, often in an ophthalmic clinic, we do come across this a lot. So if somebody was going to ask smartphones and digital media and kids, where are we heading? My single answer is disaster. In fact, I have kind of labeled the washroom in my room as like a danger room. And I've told the kids who come there who have excessive screen time that I'm going to lock you up here. So yes, I frankly am guilty of using threats, but more often than that, 90% of the patients still come back to me. The parents, they come back pretty grateful, saying that aapne jab se bola tab se bahut sudhar aa gaya hai. Another thing that I personally follow in my clinic is that no child is allowed to see any screen time during the waiting period, even though there is extra waiting period. There's no problem. We have a stock of puzzle books, a lot of story books and games and so on and so forth. And definitely inside the consultation room, if I'm seeing the parent and the child is fiddling with the mobile, they are simply threatened or they are at least rebuked by us. So these are some certain steps that we kind of try to follow. And like Dr. Hemlatha said, these have to be taken seriously. Like how much of digitalization are you going to include in academics? How much are you going to make mandatory? Because finally all this will contribute to addiction and a negative impact on the children's outcome, academic wise and overall psychology wise. Now, these are the American Academy AAP recommendations, which says that less than 18 months of age. So often the parents will again ask, okay, then how many hours can we really allow them to watch the social media? So less than 18 months, avoid the use of avoid the use of media except for video chatting. That is also very clear, video chatting with parents and grandparents, period. Then 18 to 24, little bit watch with parents. And then from 2 to 5 years, 1 hour per day. Again, co-viewing is very important, because if you're going to give a phone or a tab to the child and the child is going to sit in some other room and watch the social media, we have no control over the content. And these days, there is no limit of the content also. So the time spent with social media and or any kind of digital screen, as well as the content, needs to be watched. So I also tell a lot of parents that, okay, you feel the child is a total addict. Like just half an hour ago, we saw a child who's watching 8 hours at a stretch because some kind of binge watching is happening. So then you have to treat them like addicts, where we say, okay, you watch that, but you watch it on the, you take breaks and watch. And second is you watch it on the TV screen, or the desktop. You're not watching it on the mobile, so that we know what is being watched. And obviously, we have to designate media free times. So dinner, driving, or bedroom. A good idea to keep the charging plug away from the bedside. Okay, those kind of ergonomic things. Another suggestion that goes out to many families, especially in India when the child is in 10th, 12th, those are the times most receptive. Everybody's most receptive. So we suggest that after 10 p.m. switch off the Wi-Fi connection, so that people settle down and go off to sleep. Whether they are kids or adults, it doesn't matter. So that is one more thing that we often suggest to reduce the screen time. So to conclude, what are the things that we can do, as caregivers and as individuals we all in the current generation are exposed to a lot of digital media time? Lessen our screen time, increase outdoor activity. Again, like the previous speaker mentioned, that even for myopia control, in fact, nowadays we write it on prescription, 2 hours of outdoor daily. It is given out as a prescription to a child who is, say, 7, 8 years old. It is unfortunate, but true. And these are the two things which really work to build up good health in terms of eyes as well as overall personality. To summarize, we went through points related to digital eye strain, or what is called computer vision syndrome, and uncorrected refractive errors, dry eye, and eye fatigue and headaches form a important part of this. We need to reduce digital media exposure as much as possible, especially the avoidable one. In the unavoidable circumstances, the 20-20 rule: for every 20 minutes of screen time, take a 20-second break. Look at an object 20 feet away. Think, blink, frequent blinking, lubricating eye drops, check for spectacle number, and have a hobby or entertainment which is non-media dependent. Now, these days, what happens? We are at work. There are many people in the IT and finance sector who are at work, and when they want to take a break, they are either seeing Insta or Facebook or YouTube or many other, Netflix binge watching, and that really doesn't help. Spend time outdoors. And okay, what was the last part? Let me see. Yeah, do not, now this is very important, do not gift any media items to kids. Now, this is again very important. Do not gift media items to kids. In fact, give them sports related. So next time a near and dear kid in your family or friend circle has a birthday coming up, you rather go to Decathlon to do some shopping rather than going to the eye store. So that is again very important. In fact, another thing I tell parents is that, okay, 18th birthday, you have money, don't gift an iPhone, go buy gold. It's okay. Indians like to buy gold and it's pretty costly. So if you want to buy something if somebody is very dear to you and you want to express that love in the form of how expensive you want the gift to be, let it be gold or silver. Let it not be an iPhone. Okay. So with these points, we come to the end of today's talk. I would also take this opportunity to thank the organizers and invite you to our annual retinoblastoma awareness CME. We do it in the second week of June, and this year we are doing it on 21st June, Saturday. It's a physical event at NHSRCC hospital, and we are going to talk about most of the eye cancers and pediatric eye tumors. Thank you so much for a patient listening. And if there are any questions, please let us know.
Thank you, Dr. Himika. I request the audience, if there are any questions, if you have any questions to ask, any doubts, please ask. Or else we will go to the next speaker. What we understand, Dr.
I think this will be the last one.
Yeah, I covered that spectacles and all newer treatment modalities of myopia.
That was covered. So
Okay.
so Dr. Hemlatha covered 2 things.
All right.
Please name the eye drops. They come by the name of Flogel, Just Tears, if that was for me. Yeah. Or you just said Refresh Tears, that is the one internationally available. They are all available over the counter in India as well as abroad. And you tell them tear substitutes, whatever is available locally, they will give you.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone.
Thank you, Dr. Himika, Dr. Himlatha, and Dr. Harshada. Thank you very much. Thank you, audience.
Thank you.
Thank you. Bye.